Alrighty, let's kick off some pulmonary rehabilitation. So you can go ahead and pause if you want to read through the objectives and points of learning today. What are our indications for pulmonary rehab? So we have obstructive and restrictive lung diseases, and patients who are going to be under consideration for pulmonary rehab are going to have one of those lung diseases. And so our obstructive diseases are going to be things like COPD, persistent asthma, bronchiectasis, sorry. And then our restrictive diseases are going to be our interstitial fibrosis, sarcoidosis, kyphoscoliosis, Parkinson's, lung cancer, pulmonary hypertension, before and after lung transplant, before and after lung reduction surgery, and our neurological conditions such as spinal cord injury that impact breathing. We've got absolute and relative contraindications listed here. Keep these in mind for consideration in how you select your exercises and what patients you will have to hold off on. We'll review those contraindications again in a little bit. But we need to start off by looking at the respiratory physiology. And so it's important to understand how we calculate lung volumes and lung capacities. And so multiple volumes make up a capacity. A volume is a single measurement. Capacities are the combination of multiple volumes. And so when we think about normal breathing, taking a breath in and out at rest, just sitting here, that is our tidal volume. And so that is that middle line in our graph labeled TV, where it is just a normal breath at rest in and out. Our inspiratory reserve volume is where we extend above that line on the graph. And so you can see IRV listed there. And that's when you sit and you take a full inhalation. You take that maximal deep breath and you go. And then we can exhale out our normal breath. And so we've released that inspiratory reserve volume and our tidal volume. And then we get down into our expiratory reserve volume. And that's the breath that you have to push out. And so that's that extra bit at the end. The residual volume is something that you cannot affect. That is the amount of air that just remains in your lungs as a matter of occupying space. And so our inspiratory reserve volume plus our tidal volume plus our expiratory reserve volume equals our vital capacity. And our vital capacity is the maximum amount of air that we can take all the way in and exhale all the way out. Our total lung capacity is our vital capacity plus our residual volume. And so we have our tidal volume, our inspiratory reserve volume, our expiratory reserve volume, and our residual volume to make up our total lung capacity. And that's the total amount of air that your lungs can hold overall. Our tidal volume should remain stable over the course of a lifespan, and things that are affected end up being the residual volume in patients like with emphysema or COPD, where they have air that remains trapped in the lungs, and so they have an increased residual volume and a decreased expiratory reserve volume. And so it's important to understand how these all combine to give us an understanding of patients' lung function and how they will influence our different tests and pulmonary function test outcomes. So when we look at the difference between our restrictive lung diseases and our obstructive lung diseases in regards to these volumes and capacities, in restrictive lung diseases, we're going to see a decreased inspiratory reserve volume and a decreased total lung capacity. And you can associate this with something like a lung resection falls under a restrictive lung disease. And so if part of the lung has been removed, then obviously the total lung capacity is going to be reduced. And so we'll also see a decreased expiratory reserve volume and a decreased vital capacity. But that's going to be consistent regardless of what type of lung disease we're looking at. With obstructive lung diseases, we're going to see an increased residual volume, and that's that air trapped in the lungs, and an increased total lung capacity. And that's just due to the expansion of the alveolar sacs over time because of the air occupying space and decreased elasticity in the lung tissue. And so if we look at the primary difference between these two, we have a decreased expiratory reserve volume and a decreased vital capacity in both instances. We're going to see a decreased inspiratory reserve and decreased total lung capacity in a restrictive lung disease, increased residual volume, increased total lung capacity in an obstructive lung disease. So flow rates reflect the ease with which the lungs can be ventilated. And we talk about the difference between ventilation and respiration. Ventilation is the process of getting air in and out. Respiration is the process of gas exchange that happens within the lungs. And so our flow rates are assessments that help tell us how effectively the lungs can be ventilated in order to allow respiration to occur. So common ones that we'll see are going to be FEV1 and the FEV1 over FVC ratio. And so FEV1 is the forced expiratory volume in 1 second, and FVC is the forced vital capacity. And so when we look at FEV1, that is going to be a rate of how fast air is traveling when the patient exhales in that first second. When we look at FEV1 over FVC, that is going to be a ratio, and that is going to take that first rate of how fast that air travels in the first second over how much total air is leaving within that full exhalation. And so when we compare data across all different populations, restrictive lung diseases, obstructive lung diseases, and healthy individuals, we see a difference in that FEV1 to FVC ratio. Healthy individuals have an FEV1 to FVC ratio of 0.70 or higher. And we typically don't see an impact to FEV1 over FVC in patients with restrictive lung diseases. But we do see an impact to this value in patients with obstructive lung diseases. Patients with obstructive lung diseases will have a reduced FEV1 to FVC ratio. And so we need to be able to identify that not only for clinical application, but also for licensure questions and being able to determine the type of lung condition that we're looking at. And just remember that respiration is the process of the gas exchange within the body, and understanding the difference between stating that a patient has difficulty with respiration or difficulty with ventilation, because one is more of a mechanical process and one is more of a chemical process. Ventilation is going to be more mechanical. Can we get enough chest expansion? Do we have the muscular strength? Do we have the ability to draw air into the lungs? Respiration is going to be more of the chemical process. Is there sufficient blood flow for that gas exchange to occur in the lung tissues to then oxygenate the blood for the body? This chart breaks down the differences between restrictive lung diseases and obstructive lung diseases based on FEV1 to FVC ratio. And so if we look at this flow chart, their pulmonary function testing, their FEV1 to FVC ratio, is it greater than or equal to 0.7? If it is, then we're going to travel over towards that left side. If it's not, then we're going to travel over towards the right side. So following the path for no, then we look at, is their forced vital capacity greater than 80% predicted for their age? And if it is, then we're looking at an obstructive lung disease. If it is not, then we look at whether or not their total lung capacity is greater than 80%. If their total lung capacity is greater than or equal to 80% of predicted for their age, then we're still looking at it being an obstructive lung disease. However, if they have any reduction to that total lung capacity less than 80% of predicted for their age, then we're looking at more of a mixed lung disease where we could have components of obstructive and restrictive. So coming down from there, you've got different pulmonary function tests you can look at from your obstructive lung disease branch to see whether it's pathology where there's air trapping present or there isn't air trapping present. and that can help you determine what kind of breathing techniques to give your patient. Um, this chart also breaks down the major diagnoses for obstructive lung diseases with their pulmonary function test indicators and severity levels. And so I would reference those in order to be able to apply that information when you study for the boards. If we go back up to the top and we follow over from our FEV1 to FVC ratio, and there's a normal ratio there, then we can follow it down to our restrictive lung diseases. And from there, determining if the forced vital capacity is greater than or equal to 80% of predicted for their age will determine whether it's a healthy individual or there is presence of a restricted lung disease. And so when we have a reduction in forced vital capacity, then that is likely correlated with a reduction in total lung capacity, and that is the primary problem that we're seeing in patients with a restrictive lung disease, is that they have that reduction in total lung capacity. And so again, breaking down from there, this chart gives you general examples of restrictive lung diseases, but again, their levels of severity based off of the percent impact to total lung capacity. So kind of an overview of major diagnoses that we'll see in physical therapy that are associated or with chronic lung conditions. And so our restrictive lung diseases are going to be things due to interstitial causes, chest wall diagnoses, neuromuscular diagnoses, like we talked about spinal cord injury earlier, lung cancer with the presence of a tumor, obesity, and lung resection. Obstructive lung diseases are going to include COPD, emphysema, asthma, cystic fibrosis, bronchiectasis, and bronchiolitis obliterans. Before I move on to a little bit deeper discussion of some of these diagnoses, I want to note that this is more in depth regarding chronic lung diseases because that is going to be more of the patient population that we are applying our respiratory or pulmonary rehab interventions with, and so it's important to be more versed for the therapeutic application in this context. But it is also important that you review your other pulmonary diagnoses from pathology like pulmonary edema, pulmonary embolism, atelectasis, all of those things, because in the realm of pulmonary application for your licensure, those things are going to be relevant in exam questions. And so while it's not exactly pertinent for this specific lecture in this immediate moment, it is relevant information. If you feel rusty on it, please revisit that information from pathology. But breaking down into COPD, so chronic obstructive pulmonary disease, more commonly known as COPD, has risk factors that include a history of smoking and different occupational exposures that have caused lung damage throughout the course of the lifespan. There is an ABCD assessment tool that is outlined on page 438 in your textbook. Clinically, I have not seen this applied and I have not come across reference of it for your licensure exam. However, the O'Sullivan textbook is a book that your licensure exam has as a standard reference on there, and so at least familiarizing yourself with the ABCD assessment and knowing its association with COPD might be an important tool for identifying information in those scenario-based questions. There's also a clinical presentation outline on figure 12.5 and 12.7, but we are going to see if this video will work as I try to play it and record it through here. If it does not, please go into the PowerPoint version of just the file that is uploaded for this video and watch the videos independently.
Understanding Chronic Obstructive Pulmonary Disease, COPD. Chronic obstructive pulmonary disease, or COPD, is a lung disease that makes it difficult to breathe. COPD is a long-term disease that often gets worse over time and is characterized by inflammation and severe limitation of airflow in and out of the lungs. COPD is an umbrella term used to describe a group of breathing conditions, the most common being chronic bronchitis and emphysema. Many people living with COPD may have both emphysema and chronic bronchitis. A few people have both asthma and COPD. Cigarette smoking is the leading cause of COPD. Long-term exposure to secondhand smoke or irritants such as air pollution, dust, or workplace fumes, and biomass exposure such as wood smoke can also contribute to COPD. An uncommon genetic disorder called alpha-1 antitrypsin deficiency is sometimes associated with COPD. Although respiratory infections such as influenza and pneumonia do not cause COPD, they can make people with COPD very sick. Therefore, it is very important to keep these vaccinations up to date. At first, COPD may cause no symptoms or only mild symptoms. As the disease progresses, common symptoms include shortness of breath, wheezing, and chest tightness, especially with exercise, and an ongoing cough, often with a lot of mucus. As COPD symptoms worsen, breathing requires much more energy, and it can get harder to exercise or do routine activities like getting dressed or climbing stairs. This may lead to fatigue, weight loss, and muscle loss. People with COPD can experience a variety of symptoms. Different stages of COPD range from mild to moderate to severe. In normal functioning lungs, when air is inhaled, it travels down the windpipe and into the airways, or bronchial tubes, of the lungs. Inside the lungs, the airways branch out into smaller and smaller tubes called bronchioles that are rich in blood supply. At the end of these tubes are billions of tiny air sacs, called alveoli. Normally, the walls of the airways and air sacs are elastic and flexible in nature. Inhaling causes each air sac to fill with air. Exhaling causes each air sac to deflate. Efficient uptake of air into the lungs provides oxygen to the blood, which is then carried to all parts of the body. In COPD, however, the airways become thick and inflamed, and they produce more mucus than usual. This mucus can clog the airways and makes it hard to breathe. In COPD, the walls of the air sacs in the lungs are damaged and lose their elastic quality. The air sacs get floppy, broken, and lose their shape. As the air spaces get larger, air gets trapped, and there are fewer air sacs to supply oxygen to the blood. Because air is trapped in these air sacs, it is difficult for lungs with COPD to deflate like normal lungs. This trapped air makes it harder to get fresh air into the lungs and makes breathing more difficult. COPD is the third leading cause of death in the United States and affects more than 13.5 million Americans. It is predominantly diagnosed in middle-aged individuals older than 40 years and is present in both women and men. Although COPD is more common in men, more women die from this disease each year than men. The rate of COPD continues to increase worldwide due to smoking and worsening air pollution. While there is no cure for COPD, you can take steps to feel better, stay more active, and slow disease progression. COPD can be managed by consulting early with your healthcare provider, seeking diagnosis and intervention therapies, and adopting lifestyle changes that include quitting smoking, pulmonary rehabilitation, healthy eating and exercise, and maintaining a positive outlook.
Asthma is another obstructive lung disease where the air gets trapped in the lungs, and the diagnosis is based on the patient history and their response to bronchodilators. It can be allergic or non-allergic, and so it can have seasonal irritants or not, depending on the patient's diagnosis. The air is narrow and trap air inside the lungs, and so while the perception is that patients are, during an asthma attack, are having difficulty getting air in, it's actually that they are not able to get air far enough out that they can then replace it with fresh air. And so it is important to use recovery breathing, like pursed lip breathing, with these patients to extend their exhalation time and decrease the inspiration time to try to get more air out. Cough, dyspnea, or wheezing with the chest held in an expanded position is the common presentation for a patient experiencing an asthma attack. Cystic fibrosis is a genetic disease that affects the excretory glands of the body. It will primarily affect the lungs and pancreas as the most impacted organs. And essentially, it causes the mucus of the lungs that we need in order to maintain surface tension, prevent alveolar collapse, and all of those things. We need that mucosal lining. But in cystic fibrosis, that mucus becomes too thick, and so it inhibits breathing and becomes difficult for patients to get rid of the secretions. They'll produce a thick bronchial secretion, and vibration therapy has been shown to be effective in the helping treatment of cystic fibrosis patients, in especially improving oxygen saturations because the vibration helps to clear away some of that mucus. But this results in obstructive impairments with chronic deconditioning, and we might not be able to treat the chronic nature of cystic fibrosis, but our goal is to help treat the deconditioning and functional limitations that develop as a result of cystic fibrosis. Looking at restrictive lung diseases, these are referred to as interstitial lung diseases that result in deficiency expanding the lungs and a reduction in volume. And so restrictive, there is that decreased total lung capacity that we talked about. And so we can think of this like a lung resection or lung cancer where there's a tumor occupying space, or when we have stiffening of the thoracic cage due to ankylosing spondylitis. It can be a contributing factor, or different integumentary disorders. We can look at decreased muscle activation due to neurological conditions, including spinal cord injury. But overall, there's something that is limiting the lungs from getting air into them. And so it's divided into two groups, those with a known cause and those that are idiopathic. The pathophysiology is defined as chronic inflammation and thickening of alveoli and interstitium fibrosed distal air spaces, reduced lung volumes, hypoxemia, and cor pulmonale, which is going to be more of that right-sided heart failure. Their clinical presentation is going to include dyspnea with activity. Medical management of patients with chronic lung conditions includes patient education regarding smoking cessation when that is present, providing behavioral therapy and pharmacological, or not us providing pharmacological, but recommending pharmacological intervention for smoking cessation as necessary. There are pharmacological agents that you can look at in your textbook on, I don't remember what page, but table 12.1. Bronchodilators are going to be the most commonly seen in patients with pulmonary conditions, and that's going to apply to more of our obstructive lung diseases because of the limitation in being able to get air out because of those narrowed air pathways. The bronchodilators help to open those up without allowing for collapse of the alveolar sacs. Restrictive lung diseases don't tend to respond to pharmacological agents with the same effectiveness, and so those are treated more on a diagnosis basis for what the other causes or symptom propagation comes from. And then patients may also be on supplemental oxygen, and ultimately our goal in patients who are appropriate to wean off of oxygen is to increase activity levels with decreasing amounts of supplemental oxygen. And so the patient may be on oxygen in the room, but during therapy, we may try intermittent trials of putting them on room air and seeing how their O2 sats stabilize and are they able to recover, and can we get them to a normal oxygen saturation just at rest, but with teaching of proper breathing techniques. And that is one of our primary goals through pulmonary rehab. Looking at physical therapy management, their goals and outcomes you can look at on page 499. Overall examination, again, obviously this is going to be initiated by the physical therapist on the initial evaluation, but they are things that you as the PTA need to be familiar with in order to be able to follow up for reassessment, discharge, and just even overall monitoring of your patient. So vital signs are going to be big, with our O2 sats being our primary vital sign for pulmonary rehab because oxygen saturation is a huge component to why we care about how a patient is breathing. We're going to utilize observation, inspection, and palpation, and we're going to document things like the patient's breathing pattern. And we'll go into different breathing patterns for documentation purposes in a little bit here. But being able to note what you see and having a medical way to represent what you see is important in pulmonary rehab patients. Auscultation of the lungs, you're going to want to listen to the different sites on both the anterior and posterior chest to hear all of the different lobes of the lungs and identify any abnormal sounds. There are measurements of dyspnea and quality life indicators. We're going to do some measure of function, whether that's coming back and looking at our objective measures that we'll talk about here in a minute, or just overall patient report and taking one of those types of assessments. Measurements of strength, we sometimes need to be careful in our patients with pulmonary dysfunction because we don't want to have them Valsalva. And so traditional manual muscle testing may or may not be appropriate depending on the patient. And that might be a point where you have to make that consideration, or you need to at least follow up with the question for your physical therapist about whether or not it is appropriate when it comes reassessment time or discharge time. And so sometimes there might be overall indicators of strength or more functional indicators of strength, like a 5 times sit to stand that's used for lower extremity strength, that is used in place of traditional manual muscle testing when isometrics aren't appropriate. And so, again, at least asking the clarifying questions where that is concerned. Lab tests, go ahead and see the lab values from the cardiac rehab presentation. Again, the same concerns are present there. There is a lot of overlap between our cardiopulm patients, and so those lab values and cutoffs remain true. And then exercise testing in patients with pulmonary disease, you can look at on 12.6. A lot of exercise testing that they're talking about in the textbook is something that's going to be done in the patient's doctor setting and not the therapy clinic, and that's not necessarily the focus of our efforts, and so I'm not going to spend a lot of. So the 6-minute walk test is going to be the gold standard for assessing aerobic capacity, and so we want to try to implement the 6-minute walk test as often as possible in patients who require pulmonary rehab because it's going to give us the best indication of their progress and functional capacity. We can supplement this with the 2-minute walk test when appropriate, when the patient's going to experience a floor effect as a result of the 6-minute walk test being too long of duration, then a 2-minute walk test would be appropriate. We just want to be mindful that we avoid the risk of a ceiling effect on the 2-minute walk test and don't limit our patient's ability to progress with a 6-minute walk test. We can also utilize things like the short physical performance battery, the 2-minute step test, and the 5 times sit to stand, all of which are going to give us some indication of the patient's overall functional capacity. We can do things like the 30-second sit to stand. There's plenty of different functional assessments that we can supplement with as necessary, but it's important to know that the 6-minute walk test is the gold standard, and if we are looking at a pulmonary patient in the context of the licensure exam, there's likely going to be information related to that data collection. Looking at the different breathing patterns that we want to be able to observe, assess, and document. We've got apnea, which is the absence of spontaneous breathing. Blott's breathing pattern is irregular breathing with the breaths vary in depth and rate with periods of apnea. It's often associated with an increased intracranial pressure or damage to the medulla. And this is going to contrast with your Shane-Stokes breathing pattern, which is a decreased rate and depth of breathing with periods of apnea that can occur due to central nervous system damage. So Blott's is a little bit more irregular, where Shane-Stokes is more periodic, where breathing progressively gets faster and deeper, and then slowly gets slower and shallower until there is a period of not breathing, and then it ramps back up again and kind of follows this periodic cycle. Whereas Blott's breathing pattern is more irregular with breath and depth and periods of apnea. Bradypnea is slower than normal respiratory rate, which is going to be less than 12 in adults, and it can be associated with neurologic or electrolyte disturbance, infections, and it's also associated with high levels of cardiorespiratory fitness. So bradypnea is not necessarily something that's pathological or worrisome, but it is something that is worth documenting when it is observed. We talked about Shane-Stokes. Eupnea is a normal rate and depth of breathing. Hyperpnea is an increased rate and depth of breathing. Hypopnea is a decreased rate and depth of breathing. Tachypnea is faster than normal respiratory rate, which is going to be greater than 20 in adults. And so tachypnea and bradypnea are only going to reflect a change in rate. When we look at hyperpnea and hypopnea, those are going to reflect a change in rate and depth. Respiratory acidosis occurs when there's retention of carbon dioxide by the lungs. And so we have a decreased ventilation, which results in decreased oxygen in the blood, and patients will demonstrate rapid, shallow respirations. And this is more commonly going to occur in our patients with COPD who have that airway obstruction with a decreased alveolar capillary diffusion, and that's where the CO2 is being retained. We want to pay attention for changes in blood pressure. These patients may demonstrate a decrease in blood pressure, essentially as the body is trying to regulate what's going on. It doesn't want to send this excessive amount of carbon dioxide out to the blood, so it's decreasing the perfusion. And we're going to observe symptoms like a headache, drowsiness, dizziness, and disorientation or confusion. Patients developing respiratory acidosis is going to be clear, hey, something's wrong here. And so we may not know definitively that they are developing respiratory acidosis because we're not going to have a blood pH level in that moment. But if we are seeing the hypoventilation with the rapid, shallow inspirations, we're noting that drowsiness, dizziness, or confusion, and we know that they have a pulmonary condition, we need to know that there's a potential risk for this. So maybe we take a break from our activity, we assess the situation, do some deep breathing exercises, see what their oxygen saturation is looking like, determine what the patient's needs are. Maybe they're going to require supplemental oxygen at that point, and they are not able to get the the excess carbon dioxide out with their ventilatory capacity. And so being mindful of the symptom presentation will help you identify the correct course of action for helping the patient get the help they need. We can contrast this with respiratory alkalosis, which is going to be a loss of CO2 from the lungs, which causes an increase in the blood pH. And we'll see this with hyperventilation, with an increased rate and depth of breathing. And they'll have an elevated heart rate, so tachycardia. Blood pressure may or may not be affected. If it is, it tends to decrease, but it may stay normal. We will see symptoms like numbness and tingling of the extremities or hyperreflexic DTRs. Patients with severe respiratory alkalosis may develop seizures, and so if a patient has no previous history of reporting numbness and tingling of the extremities while they're doing exercises with you, but they do have a respiratory condition, and now they are telling you that they've got numbness and tingling, and you check their heart rate and you see that it's elevated, we need to say, oh, well, maybe respiratory alkalosis is developing. Let's take a break. Let's assess all of our vitals. Let's see what's going on as far as how the patient is breathing and if there's anything that we can do to correct their breathing and address the cause of it. Lung auscultation. So we've got points on both the anterior and posterior chest that need to be assessed for auscultation. And so this video is going to take you through a demonstration.
Hi, Katie. Andrew Bartlett, physical therapist. How are you? Good, thank you. We are going to do the borders of the lungs, and then we're going to go through some heart auscultations. Okay? Mm-hmm. So, just for purposes of defining where the lungs are, in terms of the superior border, they're going to be above the clavicle, like the middle third clavicle, and then for the anterior borders, going from the sternoclavicular joint down to about the xiphoid process from the sixth rib would define the anterior borders of the rib. And on the left side, around that fourth rib area, which pretty much lines up with the nipple line, it jets out a little bit to make room for the heart. And then for inferior borders, xiphoid process, turn to around T10, and you can line yourself up with T10 going from the inferior border of the scapula, T7 going down to T10. So from T10 to the xiphoid process, approximately the inferior borders. And then for posterior borders, going from T10 all the way up to C7 would define the posterior borders. For the oblique fissures, you can turn it back towards me. But the oblique fissures, which are on both sides, would go from T3 all the way down to the costochondral junction around rib 6 on both sides. And then on the right side, it has a horizontal fissure, and going from the mid-axillary line where it crosses the oblique fissure, going over towards the sternum, just above the breast is usually would define the upper lobe, middle lobe, and lower lobe on the right. All right, so for a long auscultation, some key things to remember: have the patient take nice big breaths, and I'm going to give you time in between breaths so you don't hyperventilate. Make sure that using the diaphragm, you're going to use nice firm pressure. So I'll name them as we go through. So on the right side, you're going to go apical. And just for time's sake, I'm going to go a little bit quicker. And you're going to go apical posterior on the left, above the clavicle. Anterior for the right upper lobe. Anterior for the right upper lobe, or left upper lobe. For the right middle lobe, the lateral segment, it's going to be, excuse my reach, be approximately right there. Good. And the superior lingula, which is part of the left upper lobe, is going to be, again, around the nipple line, a little bit above it on the side. Good. Thank you. And then for the medial section of the right middle lobe is approximately the same area, but more medial towards the sternum. And then for inferior lingula, approximately a little bit below the nipple, a little bit more towards the sternum. And then for the lower lobes, for both the right and the left, or anterior basal, you can use mid-clavicular line, go lateral to that. Remember the ribs, or the lungs end approximately at the rib 6 around the xiphoid process. So this would be anterior basal, which is part of the right lower lobe. Anterior basal, part of the left lower lobe. Good. All right, and then we're going to have you turn around. And on the right side, you can do posterior, which is part of the right upper lobe. Just pretty much a little bit above the superior angle of the scapula. Apical posterior, part of the left upper lobe. Good. And then for the lower lobes on the right, you're going to have the superior basal, kind of mid-scapula. Okay. And on the left, for left lower lobe, superior basal. Okay. And then you're going to have lateral basal. You can use the inferior angle of the scapula. Thank you. And you're going to go lateral to that for lateral basal, which is part of the left lower lobe. You can do the same thing on this side, inferior angle. Thank you. And lateral basal. And then lastly, you're going to do posterior basal. Again, inferior angle, but more medial to that. And posterior basal on the left. Good. Feel okay, Katie? Good. So quick, but those are all the areas and bronchial segments that you should also take. Thank you.
So, what are we listening for when we are auscultating the lungs? And the difference between normal sounds and abnormal sounds are something that you can't really describe. There are sound or descriptions like crackles and wheezes that go with our adventitious or abnormal sounds, but it's difficult to describe them. So I went ahead and put another video in here to give you an understanding of what they are, and you guys are going to in the lab practice listening to each other's lungs and determining whether or not they are normal, abnormal, and at all of the sites. And so hopefully with that exploration through everybody in class, you will be able to determine what normal sounds like at the very least.
Hey everyone, this is Sarah with RegisteredNurseRN.com. In this video, I'm going to let you listen to 6 abnormal lung sounds, which will include wheezes, stridor, crackles, and pleural friction rub. This will be part of a review series of the lungs. Also, be sure to check out the video on normal lung sounds as well as a lecture and skills demonstration, which is part of this series. So let's get started. Okay, thank you so much for watching. Remember, you can go to our channel to find more videos on nursing skills, NCLEX prep, and more. So please subscribe and share this video with others.
So it's important to note that crackles can indicate a wide range of problems from pneumonia to pulmonary edema, and so you can't assume what you're hearing based off of the sound of crackles. Wheezing most often indicates constriction of the airways, and the stridor most often indicates an obstruction of the airway. Again, these are not diagnostic in nature, but they do help paint a fuller picture, and so we want to make sure that we know how to auscultate, where to auscultate, and how to appropriately document what we hear.
Hey everyone.
So exercise prescription of these patients. We're often treating systemic problems and comorbidities, not necessarily lung function, and so we want to consider what their functional capacity is, what their pulmonary aerobic capacity is. And so our specificity of training and demand on the cardiopulmonary system are important considerations when selecting our mode. We want to make it patient applicable. And again, we are trying to restore or maximize function in somebody who is significantly declined. And so creating interventions that provide meaning and purpose and restoration to what the patient's real function is going to be very important in our selection of exercises. The intensity should try to reach but not exceed a 13 out of 20 on an RPE scale. So again, we're going to work with patient tolerance. We're going to monitor their O2 saturation so that we know that we're not pushing them to too high of an intensity as we are working to build their cardiac or cardiorespiratory endurance. So we'll utilize rest breaks as needed, but our goal is to work to be able to push to a 13 out of 20 on that RPE scale and be able to maintain that for a period of time. Duration-wise, our ultimate goal is to achieve 20 minutes of continuous activity with no rest period. We want to encourage bouts of at least 10 minutes, but most patients are going to have to work up to that. And so we start where the patient is and utilize rest breaks that we try to progressively shorten our rest breaks and work towards more continuous activity. Pushing the patient too far too fast is the surest way to make sure they won't make it to the end of your treatment session. But we also have to make sure that we don't take it too easy on them where we're giving them too many rest breaks and we're not sufficiently taxing the cardiorespiratory system to see any improvements in pulmonary function. Frequency-wise, we want to use frequency to balance duration. So if they can't handle long durations, then we implement more regular intervention in order to try to find a balance in overall volume of exercise. Our ultimate goal is 3 to 5 times a week at 20 minutes of continuous activity. When selecting interventions for our pulmonary patients, we obviously want to make sure that we're including aerobic training. And so we will have check-in with vitals and all of those things before we initiate any kind of aerobic training. Warm up and cool down to sandwich our aerobic exercises because we have to remember how closely linked our cardiopulmonary systems are and how taxing the pulmonary system can also cause adverse effects on the cardiac system. These patients will benefit from learning breathing exercises, so we can use tactile cues and manual resistance to the rib cage while encouraging breathing through the nose for things like chest wall expansion. And so that's something that you as the therapist can start with the tactile cues on the lower rib cage. And as the patient is able to understand that tactile cue of pushing into your hands to increase chest wall expansion, you can provide a slight pressure to provide manual resistance to those inspiratory muscles and increase inspiratory muscle strength. Our primary goal is to discourage accessory muscle activation. And so, that the chest wall expansion is one technique. We talked in the cardiac video about diaphragmatic breathing and how you can use tactile cues and manual resistance over the diaphragm to promote appropriate breathing there. And I'm going to give you guys a thing on pursed lip breathing here in a couple of minutes. Pursed lip breathing is going to be one of our big recovery things, and so that's something we are going to regularly teach patients. We also want to encourage the use of their inspiratory devices, and so things like their incentive spirometer to help prevent alveolar collapse. Patients, especially in the acute care setting and then being discharged from the acute care setting, are given an incentive spirometer to help open up the airways, clear any congestion through the bronchial pathways, and prevent alveolar collapse. And a lot of times it will sit on the bedside table and never be touched, and nobody ever actually uses it. And so educating your patient on the benefits that that incentive spirometer will provide them in restoring their functional abilities is really an important carryover that we can provide through physical therapy. When we are looking at general strength training, we want to address extremity training, and so both upper and lower extremity strength exercises, again, considering patient function and making exercises as applicable and specific to the patient's needs and current level of function as possible. We have to remember that as a result of pulmonary conditions, patients are often deconditioned, and so they've had a more sedentary lifestyle, and so as a result of that, they will have extremity weakness, and that is why extremity strength training is an important component. We also want to encourage ventilatory muscle training, so when we progress our breathing exercises to providing manual resistance instead of just tactile stimulation, we've gone from breathing exercises to ventilatory muscle training, where we are trying to actually strengthen those inspiratory muscles. And so we can do this through therapist intervention with those techniques, or we can also do it through encouraging use of their inspiratory muscle strengthening devices, things like flutter device and other muscle trainers work to provide resistance to airflow as patients breathe through them. And so that resistance helps to, again, just strengthen those inspiratory muscles. It's important that patients know how to use the correct muscles and not accessory muscles when we progress them to ventilatory muscle training. And so breathing exercises are an important first step to make sure that they are using their respiratory muscles and not their accessory muscles for initiating ventilatory muscle training, because otherwise we're just going to strengthen the compensations, and we don't want to strengthen the compensations. Again, we can train appropriate inspiratory muscles by providing tactile cues and or manual resistance to the chest wall or diaphragm as the patient can tolerate, to reduce use of accessory muscles for inspiration. We also want to incorporate balance training when we look at these patients being deconditioned and having more sedentary lives prior to physical therapy intervention. That means that they are also at an increased fall risk, and so balance deficits are typically present. And so we want to make sure that in our application of function, we are addressing those balance deficits and incorporating sufficient balance challenge within the patient's capabilities. Our exercise progression should always first be directed towards increasing the number of continuous minutes of exercise and decreasing the amount of time spent in low intensity exercise or rest periods. And so we're not so much worried about making that 20 minutes with 10 breaks into 60 minutes with 10 breaks, but can we make that 20 minutes more of 20 minutes continuous activity and decrease rest breaks, so that way we're increasing that overall aerobic endurance. Let's review the contraindications for treatment in patients with pulmonary dysfunction or disorders. And again, talking about the overlap between cardiac and pulmonary conditions, we are going to have some overlap in our contraindications here. So unstable cardiac arrhythmias, severe untreated pulmonary hypertension or unmanaged hypertension, I think qualifies there as well. Advanced liver diagnosis, that's going to, again, become part of the medical team's advice and what needs to happen, but liver function is going to be tied with kidney function and heart and lung function, and so we need to be mindful of somebody with advanced liver disease may have impacts on respiratory function but may not be appropriate for therapeutic intervention. Unaddressed severe orthopedic problems, and that's just tying back to, are they physically safe to get up and move and try to improve endurance and aerobic capacity. CVA with little to no mobility. We're not trying to promote aerobic activities when a patient doesn't even have seated edge of bed balance, and so pulmonary rehab intervention specifically would be contraindicated in a patient with CVA with little to no mobility. And severe cognitive deficits, again, we want to promote safety, and so if the patient's unable to understand the instructions being provided for aerobic exercise, then that's going to be a contraindication. And then monitoring their oxygen saturation. If they fall below 85%, then we want to stop exercise, have them breathe, monitor saturation to see that it rebounds, document all of these things. What level of exercise were they at when they desaturated? How much time did they need to recover? Did they need to be placed on supplemental oxygen, or were they able to recover on room air? But all of these things are going to go into your documentation to support a patient's demonstration of progress with their functional endurance and capacity. Giving a patient a home exercise program, patient education, and activity pacing are going to be our key components to their HEP. And so how do we educate them on taking their day-to-day lives, trying to implement a little bit extra activity that we've prescribed, and do it safely. And so we can use things like an activity log that helps them, understand and track their physiological response, education on utilization of breathing exercises to recover and timeline to recover. But we want to make sure that we're emphasizing increased activity within the constraints of safety when we're prescribing a home exercise program in this patient population. And then pursed lip breathing, is going to be one of our primary means of recovery breathing, and it is most effective for patients with obstructive lung diseases because it increases the exhalation time compared to your inspiration, and so that helps to get more air out. However, because of its ability to also regulate the nervous system and cause the whole body relaxation, it's an important recovery breathing technique to utilize in patients of really any pulmonary condition and anybody who's demonstrating desaturation, because it's just going to help them restore a normal rate and rhythm of breathing. So we'll take a look here.
Pursed lip breathing is one of the easiest ways to help control shortness of breath when you are active. It slows the pace of breathing, making each breath more effective. With your mouth closed, breathe in slowly through your nose. Then breathe out slowly through your mouth with your lips in a whistling or kissing position. Here's how to do it. Remember to breathe out twice as long as you breathe in, and repeat this 2 or 3 times as necessary.
And that is it on pulmonary rehab.